Welcome, Dr. Rao.
Hi, Maria.
Hi, Dr. Rao. Welcome. Thank you for joining me to discuss heart health. It's always an important topic, but even more so during the pandemic where your cardiovascular disease is an underlying condition which makes people more susceptible to severe outcomes. So this is an important topic. First, tell us your name, background, a little bit about yourself.
So my name is Ishu Rao. I am a cardiac electrophysiologist by training, which in simpler terms means that I'm a cardiologist whose specialty is electrical problems of the heart. So I grew up in Pennsylvania, went to school kind of in a few different places from Philadelphia to Houston, did some training in Los Angeles, and then practiced both in Texas and California for almost 2 decades. About a year and a half ago, I left clinical practice to join a company called Impulse Dynamics that manufactures a device called the Optimizer that for all the world looks just like a pacemaker, but works very differently and actually helps patients with heart failure live better lives, in essence. So
now, heart failure is a bit of a misnomer. Many people think it's when your heart stops. Explain what heart failure actually is.
Yeah, so if you think about the heart is a pump made of muscle. And the purpose of the heart is to pump blood and all the nutrients specifically, or perhaps most importantly, oxygen throughout the body. All the organs of the body need oxygen, all the organs of the body need nutrients, and the blood is the conduit to carry all this. And the heart pumps that blood throughout the body. Heart failure is, in its simplest description perhaps, an inability of the heart to pump enough blood forward to maintain the needs of the body. So there's a couple of different reasons that people can have heart failure. So if you think about the heart, and the main pumping part of the heart, the main pumping chamber is called the left ventricle, and it's sort of the workhorse of the heart. And the purpose of the left ventricle is to squeeze blood out to the body, and then it'll fill and then fill up with more blood and then repeat that, 60, 70, 80 times a minute. The normal amount of blood that's pumped out with each squeeze or each contraction is called the ejection fraction, and the normal ejection fraction is about 60%. So normal is 60%. We hear about people having heart attacks, and a heart attack is when the arteries, which are the blood vessels taking oxygen to the heart muscle itself, get blocked, resulting in damage in the heart muscle, resulting in a weaker contraction, an inability for the heart to squeeze as well. And you get ejection fractions of 40, 30, 20%, which you can imagine is a substantial decrease from normal. In those instances, it's pretty obvious that the heart's squeezing less, so less blood is getting pumped out to the body, and that can result in heart failure. The other sort of major cause of heart failure is when the ventricle can't relax enough to fill up with enough blood, so it consequently can only squeeze out what little amount is in it, again, resulting in heart failure. The symptoms of heart failure are, the typical symptoms are shortness of breath, meaning that the lungs, which are trying to fill that blood with oxygen, get backed up with the extra fluid that isn't being pumped forward, and people get short of breath and they can't walk as far. They have less energy, less exercise tolerance. We have patients that have daytime sleepiness, general fatigue. These are all symptoms of heart failure.
So that's really affect anyone of any age?
Yeah, we tend to see heart failure affect, we think of heart failure affecting people that are older, mostly because, your coronary arteries age and you get calcium deposits and plaque deposits that lead to heart attacks and things like that as you get older. It can affect younger people too. We see people in their 40s, which depending on your perspective is relatively young. And from my perspective, it is. But yeah, we see heart failure affect people of all ages, but it tends to tip sort of to the older population.
And we also see athletes.
Yeah, we do. Yeah, we do. We see heart failure affect athletes as well. Quite often, those athletes have heart failure from sort of a thickening of the heart muscle, something called hypertrophic cardiomyopathy. But there are various other causes as well.
How long can somebody walk around with heart failure and not be aware of it? Because fatigue is such a general um, symptom. You know, you're tired. You could blame so many things for fatigue. That are there people walking around not aware that they have heart disease?
There are a lot of people walking around that are unaware that they have heart disease. Sometimes, so what happens is that there's some really great mechanisms that the body has to accommodate for failures in one realm with accommodations in another realm. So sometimes people do have heart failure, or they have worsening of their heart function, and they accommodate. The body accommodates in certain ways to try to keep their cardiac output, which is what we call the amount of blood that gets circulated every minute, keep it in a reasonable realm so they don't have sort of kidney failure or things like this. But quite often fatigue is a result. We do see people, however, that walk around with seemingly normal energy that have weak hearts, and quite often a catastrophic event like cardiac arrest, which is an electrical storm that results in the inability of the heart to pump at all, and often leads to death, results. One of the things about that, just to clarify terms, cardiac arrest is, as I said, and it's an electrical storm that results in cardiac arrest, that results in death. And if anyone's watched any medical shows, whether it be MASH or Scrubs or one of these, you see people run in with those defibrillators. That's the treatment for.
And if someone is watching this and wants to make sure that they don't have an underlying heart condition, how do they get tested?
Yeah, so there's a couple of different ways. We all know about the EKG, and the EKG, frankly, might be the most brilliant test ever created for healthcare. It can be administered by almost anyone, gives you instant information. But an EKG is it's a little bit of a general test. It's a little bit of a gross test, meaning that it won't detect some fine problems. But for someone who's relatively healthy or not having any symptoms or anything like that, an EKG is probably the place to start. If you wanted to do a more in-depth test that's non-invasive, you would have probably an echocardiogram. An echocardiogram is a test where it's an ultrasound of the heart that can give us visualization of the four chambers of the heart, the valves, the pumping capacity of the heart, sort of the volumes of the heart. There's a whole host of different information we can get from that. Beyond that, there's a lot of other tests. You can get CT angiograms, where, again, minimally invasive, meaning you just get an IV with an injectable dye that will show kind of the arteries of the heart. A more invasive test is called a heart catheterization, where we put larger IVs into one of the big arteries of the body, either the leg or the wrist, and take long catheters, which are just hollow tubes that look like straws almost. Put them in the heart and take a look at the arteries that way. So there's a whole host of different tests, but really, if you're starting out, it's always going to be an EKG, and probably followed closely by an echocardiogram.
And what role does genetics play in heart disease? If a parent has heart disease, should you get checked?
Yeah, there's some sort of standard cardiac risk factors, and genetics is a strong one, especially if you have parents that have had heart attacks or cardiac arrest or something like that in their younger years. Once you get over your 60s, it's probably more a consequence of just gradual decline. But if you had a parent that had a heart attack in their 40s or 50s, you definitely need to have a close evaluation to modify your other risk factors. Obviously, they say the smartest thing you can do is choose your parents, which is obviously impossible to do. So you definitely don't want to be smoking. You want to make sure you're getting plenty of exercise. Your diet is good. Your your lipids are under control, these kind of things. If you're diabetic, you're controlling it. And if you're not diabetic, you're doing the things that one can do to try to prevent prediabetes.
And what role does obesity or being overweight? Because it seems like if you do have extra weight, it would put more stress on the heart to supply oxygen. Let's talk about that, because there are some people that say, I'm obese, I'm overweight, but I'm metabolically healthy. But studies have shown that someone could be metabolically healthy today, but there are long-term studies that show that same person, if followed 5 to 10 years later, does not fare well long-term.
Yeah, and I think that has a lot to do with the testing that's done. So obesity is definitely a risk and a problem, and some of it I think we are still teasing out. But the actual, until you're morbidly obese, the actual work that the heart is asked to do is probably not the issue so much as the metabolic issues that come with obesity. One of which is that you tend to have more visceral fat, which fat in your body that's surrounding your organs. And we know that visceral fat has inflammatory effects that can be negative for your heart and your vascular function. So it's not necessarily just carrying around weight, it's where that weight is, it's what that weight is, it's the fat that has sort of more biological and biochemical effects that can be negative. So those are all considerations.
And to be clear, even a thin person could have visceral fat. It's about body composition and what type of fat you're carrying, right?
Absolutely right. That's absolutely right. And you look at, they talk about the apple-shaped and the pear-shaped individuals, whereas, if you're pear-shaped, you carry more of your adipose tissue on your hips. And if you're apple-shaped, it's more central. And that central obesity does translate more to visceral fat. And that
was my next question. Is there a way to check what type of fat someone is carrying?
We look at waist, different ratios of waist circumference and things like this. We look at body mass index. By and large, as a general concept, you're probably fine looking at body mass index and staying in that 22 to 24 range, or 20 to 24 range. 25 is overweight, 30 is obese. And you really want to stay on that lower end if at all possible. There's obviously other ways to do that that are scans and things like this that can give you a little bit more information. But really, if you're looking at it on a day-to-day basis, you look and see what your ideal body weight is and try to get close to it, because typically if you do, you're going to be reducing your risk.
Now, I'm really interested in the innovation that Impulse Dynamics has, but first I want to talk about how is it traditionally treated? Before we get to this new innovation, what are the traditional methods and why are they lacking?
So the traditional methods of treating heart failure start with medical therapy. And there's 3, and actually now probably 4 different classes of medications that have been proven to be effective for patients with what we call HFrEF, or heart failure with a reduced ejection fraction. So I mentioned the ejection fraction is the percentage of blood that's squeezed out with each heartbeat, with each contraction, and normal is 60. The HFrEF, or heart failure with reduced ejection fraction, is designated as patients with EF less than 40%. And the medications that have been proven to be effective are beta blockers, and these are things like metoprolol, carvedilol, anything kind of ending with OL.
Is that a pill?
And that's a pill. Yeah, these are all medications. These are all pills. Beyond that, then there's ACE inhibitors and what we call ARNIs. That's a different type. That's a different class of medication. There's 4 different classes. There's MRAs, which are a different class of medication again. And then recently, what we call SGLT2 inhibitors have kind of made it into the 4. And all of these have shown a benefit in helping patients live longer lives out of the hospital. So that's very, very helpful, very, very beneficial. But even after that medical therapy, some patients still have symptoms of heart failure. So the next, then you start looking at what we call device therapy. So we've talked about 4 different classes of pills, of medications. Then you start looking at device therapy. So I mentioned cardiac arrest, this electrical storm that results in sudden death, and the treatment, the prevention for that. We talked about the external defibrillator, where people get shocked by these paddles or these pads. There's an internal version called an internal cardioverter defibrillator, or ICD, that's indicated for patients with EFs less than 35%, and has been proven to reduce the risk of dying. It's a straightforward procedure to implant it with a small incision right under the collarbone, 2 wires that go into the heart that function as basically a paramedic walking around with you all the time. There's a fancier version of that has a 3rd wire that can help patients with heart failure, but those patients have to have a particular kind of EKG. They have to show that some of the conduction within the heart is abnormal. And if you have that specific conduction abnormality, this device called a CRT, or a biventricular defibrillator, can improve your heart failure symptoms. The problem is only 5% of all the patients with heart failure qualify for that CRT.
Oh, wow.
So because of that, even though it's a great therapy, it's actually not applicable to the vast majority of patients with symptomatic heart failure. So that kind of brings us to the Impulse Dynamics product, the optimizer system, which functions differently than any of those therapies. So from a mechanism standpoint, it actually functions differently than, like I said, any of the medications or the devices I just spoke about.
Tell us how that works.
Yeah, so it's another device that goes in, again, under the skin, small incision. For all the world, it looks like a pacemaker. But instead of stimulating the heart to try to squeeze better or in a more orderly fashion, which is what a biventricular device does, it actually delivers a large amount of electricity during the resting phase of each heartbeat. And what that does is it really, in essence, reverses the biology of the failing heart. And it does that through a few different ways, one of which is by manipulating how calcium is used by the cells to make the heart cells squeeze more forcefully. One is that it reverses the abnormal gene profile that's seen in heart failure. So these mechanisms together result in improvement in heart failure symptoms in over 80% of patients that get this device.
What feedback have you gotten from patients so far that have used it?
The feedback has been tremendous. We've had patients, there's kind of probably the classic one from the company standpoint. We presented our data to the FDA, and we had what we call a panel meeting. So the FDA panel convenes, and incidentally, we had a 12-0 vote in our favor, which led to FDA approval. But a gentleman came to the panel, and he was one of the patients who was enrolled in the earlier studies, and he had such a compelling story. We have it on audio and transcribed and everything, but he said he was 42 years old and he was diagnosed with an ejection fraction of 15%. He had daughters that were 14 and 18 years old. His doctors told him there was nothing they could do for him and to get his affairs in order. And he even spoke about how he asked his best friend to walk his daughters down the aisle when they were ready. He then got enrolled in our clinical trial, and he got the optimizer device. And soon thereafter, his ejection fraction was 50%. And since that time, which was, I want to say probably about 18 years ago now, he said he's walked both daughters down the aisle, watched both of them graduate from college. He's got 2 grandsons, and he sent us a picture of him hiking in Yosemite.
That's wonderful. That's wonderful. So basically, his quality of life, not only did it save his life, but it improved his longevity and quality of life
Tremendously. And that's obviously a very dramatic story, but it's not actually much different than the stories we hear on a regular basis.
Do you yourself have any personal experience with heart failure with yourself or your family members?
Yeah, my dad's younger brother, actually about, 15 years ago, I was in the earlier phases of my career, and he was living in Canada, but had moved to the Northeast to be closer to his sons, my cousins. And he had bad vascular disease and bad heart failure, and he was really suffering. He was hospitalized repeatedly, and I didn't have particularly close contact with my uncle at that time, but I talked to one of my cousins, and he told me about it. And at that time, we didn't have very much to offer him. I actually suggested that he get a biventricular defibrillator. The BiV devices were relatively new at that time. He got that, and that actually improved his quality of life substantially until he passed away about a decade ago. But yeah, I mean, so I do have some personal experience with heart failure, and just kind of going through that process.
I'm sorry to interrupt. Would this have
please.
helped him if you back then?
I think it would have. I actually think it very much would have. He was one of the 5% that were lucky enough to benefit from a biventricular defibrillator. But there's the possibility that as that therapy started to be less effective in his later life, you kind of wonder if this was available, if it would have been beneficial for him or potentially helpful to him.
Right. And you hear of people getting bypass surgery. What role does that play in all of this?
Yeah, bypass surgery is, I mentioned earlier that, the heart muscle can be affected by, there's arteries taking blood and oxygen to the heart muscle. And if they get blocked, then the heart muscle dies. That's an instance where a bypass operation may be beneficial, where you have multiple blocked arteries. There's 3 main arteries that are going to the heart. And if more than one of those are blocked quite often, or one of the main ones is, then you might get an operation where a blood vessel either in the chest is redirected to go around that blockage, or a vein is taken from the leg and used for the same purpose.
Is this an alternative to bypass surgery, or another option?
So this is not so much. Bypass surgery, with the advances that have been made in catheter-based treatments, there's been a lot less need for bypass surgery these days. Your cardiologist can go in with a catheter in the wrist or in the leg and open up some of those blocked arteries and have you home the same day quite often. So bypass surgery is, and those catheter-based interventions are for blocked arteries. When we talk about treating heart failure, oftentimes we're treating the effects of those blocked arteries. So those arteries have been blocked, the heart muscle dies, the heart muscle weakens, it's not pumping enough blood. That's the role of cardiac contractility modulation therapy. That's therapy delivered by the optimizer device to help that weakened muscle, which is sort of the after effect of a blocked artery, to squeeze more robustly.
So at what stage would people benefit from this?
Yeah, it's a good question. And really, someone gets diagnosed with heart failure, they get started on those medications that I described, typically at least 3 or 4 of them. And once they get to that point, if they still have symptoms, and that means you're short of breath walking, or fatigued walking up a flight of stairs, walking a city block, putting groceries away, making your bed, if you have to stop during those activities because you just don't have enough energy or you're short of breath, then you still have symptoms of heart failure. And those are patients that should seek further therapy, because there are options, including for some patients, a vast minority, but some patients, the biventricular devices. But then again, the impulse dynamics optimizer is also a therapeutic option for those patients.
Well, that's great to know. And one of the reasons for doing this is to make people aware that the optimizer from Impulse Dynamics is available. And so do they inquire, do they ask their physician about it, or do you have a website? Where would they get more information?
So our website is www.impulsedynamics.com, and there's plenty of information on there for both patients and providers. So
And
As
by
you might-
providers, are you talking about general practitioners, cardiologists, hospitals, or all of the above?
All of the above, whether it's the cardiologist, the general practitioner, the nurse practitioner, physician assistant, the hospitalist, any or all of these people can go onto our website and get information and recommend this therapy if they think the patient is appropriate for it and meets the criteria that are listed on the website. It's a therapy. So as you may know, Impulse Dynamics is a relatively smaller company, and we're starting to really expand into the major markets around the United States, but we still have work to do in creating the kind of awareness where it's ubiquitous in every physician's office and every hospital. So any of those types of physicians or providers that want to recommend a patient for this therapy, we've got on our website actually physicians in regions around the country, and we're in almost every major market. We have physicians that have experience with this that can evaluate the patient and implant the device and provide the therapy.
Excellent. And let's talk about prevention again, because is it accurate to say that even if preventative measures are taken, or even if they had the optimizer device implanted, that it's still advisable to make lifestyle changes?
Without a doubt, without a doubt. That's a really, really good point, a really good question. Yeah, I mean, in my practice, I implanted thousands of defibrillators and BiV devices and everything. And one of the points you have to make is that this is an additional therapy to your medications and your lifestyle changes. This is not a free pass to, eat a Burger King every 3 hours. This is all incremental, but you've got to do the baseline work. You've got to take care of yourself. You've got to control your weight. If you're diabetic, you control that. You definitely should not be smoking. Exercise every day. Get good whole foods, vegetables, fruit, whole grains, things like this. This is still the basis of everything, and then everything we do is incremental to hopefully result in the best possible outcome for the patients.
Thank you. Thank you so much for joining us. I think we've covered everything. Is there anything else you want to add?
No, I think that covered everything. And again, our website is www.impulsedynamics.com. And it's got information not just on CCM, not just on the optimizer, but a host of other resources. So we encourage patients and providers alike to take a look.
Again, that's www.impulsedynamics.com. And I strongly recommend everybody go take a look, because heart health is extremely, extremely important. And if you have a family member that has, like Dr. Rao said, has gotten treatment, but you still see that they're fatigued or sleeping on the couch all the time, and not living a normal, active lifestyle, you might want to look into this. So thank you. Thank you so much.
Thank you, Maria. It's been a pleasure.